thank you very much, both David and Michael, for your overview, and thanks for inviting me here today. I'm going to ask my panel to come up and join me. I feel like a bit like Dr. Oz, with this sort of panel, so you can be the judge of that later on. It's a real pleasure for me to be here today, and probably the stupidest person in the room when I look around and see all these really, really smart people on this panel. I'm very impressed. So, you might ask, well, why am I here? Well, yes, I'm Deputy Minister from the province of Nova Scotia, and we're going through a lot of change to try and drive our use of health data. But really, I started probably 30 years ago. Actually, exactly 30 years ago. I was a family physician in Guelph, Ontario. I just left the military and had set up a practice with some colleagues of mine in Guelph, Ontario. And I had worked emergency in Guelph in 2 hospitals. And I noticed, just anecdotally, that would be no surprise to many of the people in this room, that many of the people who showed up in the emergency room were really primary care clients. And so when I was on call, I started to collect data, and I collected, and I used ICD-9 codes then, because we were one of the early, and when we built our practice, I think we were the second computerized practice in Ontario. That's 30 years ago. So I was familiar with ICD-9 code at that time, and so I would keep track of the time the patient called me, and I would keep track of the ICD-9 code when I saw them, because I had to go meet them in the emergency room. And I collected all of this data for a year, and then I started to analyze it. And what I found was that these were all pretty much primary care kinds of problems that I was seeing people in the emergency room for. And they were typically clustered in different times of the day, typically after people came home from work. And so I started a company to deliver services, an after-hours clinic, the second in Ontario. I guess I'm second in everything, but that makes me try harder. So we started a very successful after-hours clinic, so patients could come to one place, and family doctors would see them at that time, and family doctors all took part in that company, which still exists today. So I have a history of more of a serial social entrepreneur. I've started 5 companies in my career, always looking to improve access to care and using data to drive decision making. So I ended up in government really because Nova Scotia decided to consolidate their health authorities from 9 down to 1, including the Children's and Women's Hospital, the IWK, which is really an Atlantic resource. And that was a challenge that I like to take on, because for me, structure and governance is incredibly important in trying to do anything. And so that was the foundational piece. I'm now in the process of transforming the Ministry of Health in Nova Scotia, and in large part to focus on analytics and data. So we are recruiting 4 new senior executive directors, one of which is in an area called investment and decision support, which is really to grow. And we're actually creating new positions, which is a great opportunity in one's life to be able to create new positions focused on analytics, advanced analytics, and predictive analytics within government. So I'm very, very pleased to be here today to have this panel talk about game changers in real time and predictive analytics, something that's been very close to my heart for the past 30-odd years. I'm now going to introduce our speakers. I'm very pleased to introduce to you Dr. Marty Kohn. Dr. Kohn is the Chief Medical Scientist at Sentrian, which creates predictive analytic systems integrating home monitoring with longitudinal health data for patients with complex medical conditions. Dr. Kohn is a board-certified emergency physician with over 30 years of practice and management experience, and he's an alumnus of MIT, Harvard Medical School, and NYU, and he has been a healthcare executive, educator, and congressional health policy advisor. Dr. Kohn is board certified in clinical informatics, has published on clinical, technical, and management subjects, and speaks frequently on the role of big data in the transformation of healthcare. So we'd like to welcome Dr. Kohn, if you would, please.
Thank you.
Thank you. Next is Dr. Mohamed Alarakhia. Dr. Alarakhia is a family physician and the director of eHealth Center of Excellence at the Center for Family Medicine. He's in the Waterloo, Wellington LHIN, Enabling Technologies eHealth Physician Lead. Mohamed has been fortunate to win a number of awards related to eHealth, including the AFHTO Bright Light Award for leveraging technology to improve quality and efficiency of care. He was awarded the Ted Evans Scholarship for Excellence in the Principles of Family Medicine for his exceptional interest and potential in informatics and information systems. So please welcome Dr. Alarakhia. Next is Dr. Randy Giffen. He's an analytic solutions architect with IBM Canada. He's working with the Center for Health Informatics and Analytics at Memorial University in Newfoundland. Dr. Giffen is a former general practitioner with postgraduate research experience in medical informatics at the Open University. Dr. Giffen has been involved in a number of software projects with IBM, including the Eclipse project, business process management, and healthcare analytics and predictive maintenance and quality projects. He's also been a supported researcher at the University of Ottawa, where he's adjunct professor and a member of the Telfer Health Transformation Exchange. So please welcome Dr. Giffen. And finally, Dr. Heather Bryant. Dr. Bryant is the Vice President, Cancer Control, Canadian Partnerships Against Cancer. Dr. Bryant has chaired many national cancer research committees and currently chairs the Pan-Canadian Lung Cancer Network. She was the inaugural chair of the Institute of Cancer Research's Advisory Board with the Canadian Institutes of Health Research and the National Colorectal Screening Network. She currently serves as a board member for the BioCan RX, a Canadian network center of excellence. Dr. Bryant was elected to the Union for International Cancer Control, the board of directors in 2012, and re-elected in 2014. She is also the chair of the International Cancer Benchmarking Program, an international comparison of cancer survival and its antecedents carried out by Cancer Research UK. In 2015, she was named one of the 100 most powerful women in Canada by the Women's Executive Network. Please welcome Dr. Bryant to our panel. So you can see, these are a lot of really smart people. So I'm going to ask Marty to come up first and give his presentation.
So thank you very much for the invitation to be here. I've been working in healthcare and health informatics this is my 50th year now. So I started out in the 60s as an academic research biomedical engineer, and back then we had the delusion that technology was itself the solution. We invented the technology and then tried to find some way of forcing somebody to use it. And that accounted for probably 20 or 30 years of actually no impact of information technology on healthcare at all. We have learned now we need to do it differently. Okay? We need to identify a real problem in healthcare that's causing pain, okay? And come up with a strategy to improve on that problem, have a vision of what we want things to look like in the future, develop a pathway to get there, what are the obstacles to moving on that pathway, and then technology has a role in helping us overcome those obstacles. So we need to identify the problem first and have this vision of the future. So as an example of that approach is I'm going to talk about some of the work I'm doing right now and how it fits into that theory. Okay, what's a real problem right now? The cost and inefficiency of healthcare. In the United States, we just hit that magic figure of $3 trillion spent on healthcare, of which roughly a third goes to hospitalization. Now, couple that with some other things. A recent study published by Don Berwick, the former administrator for CMS in New York, and fortunately for me, my classmate from medical school, published a paper that estimated that, at least in the United States, roughly 1/3 of every dollar spent on healthcare was for things of no value. So of that $3 trillion, roughly $1 trillion was useless. So what's a real problem here is one is that inefficiency, these expenses, and not getting very good outcomes for it. Now, a large part of this cost is patients with complex multiple chronic diseases. Within the Medicare community, Medicare, Medicaid community, 10% of patients account for 73% of costs. Okay. A lot of that is inefficient. A lot of that falls into categories where it's called ambulatory care sensitive diseases, diseases whose need for acute care could be reduced if we did a better job of taking care of them at home. So that's a real problem, and that's a problem we have targeted to try to solve. Now, one of the reasons this is so inefficient and such a problem is we don't have a good idea of how to manage patients with multiple chronic diseases. Okay. If you have a patient with coronary artery disease and asthma, you cannot manage that patient or optimize that patient's outcome by individually managing the diseases because the treatments are antithetical. What makes asthma better makes coronary artery disease symptoms worse and vice versa. So the standard that we have used for many years, randomized controlled studies, don't help us here because I have never seen a randomized controlled study on patients with two diseases and how to optimize the outcome. And even when those studies are well done, whatever they are in whichever disease, it's a population study comparing one group to another group and telling you nothing about the individuals. So if we're going to make improvements on this, we need to focus on learning about individuals so that we can make better decisions for them. Now, if you listen to the genomics community, they invented the idea of personalized healthcare, okay? But they didn't. Okay? It's at least bordering on 50 years old. The first article I ever read about it, July 4th, 1968. And the reason I remember it was the first article from New England Journal that I read when I started medical school. The idea of learning enough about the individual patient that you can make decisions for that patient that are more likely to be better for that individual and not treat the patient as one of a group. So if we're learning now that we need to use more real-world data. The only way we're going to be able to individualize patients, learn about you as an individual, is to learn about you in the real world, where you live, where you work, where you carry on your activities. And so lots of articles about the combination of genetic and clinical data using mass data that you can read for the real world is the way to do this. However, if we're going to collect all this data and make good decisions about people, we have to have a reasonable model of what that life is like if we're going to try to use data to model it. And so the idea of using home monitoring data for patients with chronic disease has been around 20, 30 years. But it has not been a realistic model, which is one of the reasons that most of the publications on these efforts have shown them not to be particularly valuable. What they have typically done is take a disease like congestive heart failure, use a single measure, such as a weight scale, and if a patient gains 2 or 3 pounds or 1 kilo overnight, they assume it's fluid retention, worsening congestive heart failure, and they mark that patient as at risk for admission and try to do something. Well, several limitations there. One, most patients older patients in particular with chronic diseases have multiple chronic diseases. So if they have COPD and CHF and you only focus on the CHF and don't do anything to prevent admissions in COPD, you really haven't done a big favor for the patient. The idea of tracking weight gain, which is the most common one that's published, is problematic because it's a very late stage in the development of increasing severity in congestive heart failure. The process of congestive heart failure and COPD, diseases like that, actually starts days before the patient becomes aware. Because most all of these patients, except for the most severely ill, have some level of reserve, and they have to use up that reserve before they become symptomatic. So if you're going to identify these patients early enough, and the objective here is to identify these patients 4 or 5 days before they become sick enough to be admitted, you need to look for signs in collected data from the patient at home that says this process has started, even if the patient is not yet aware. So that means you need to look at all the diseases the patient has. If it's COPD and CHF, be prepared to come up with a set of monitoring devices and self-reported from the information from the patient that's relevant to both, not just one or the other. And we need to go a step beyond that. We need to identify patients who are likely to need heavy utilization of healthcare in the near future. But the step beyond that is the relatively new idea of impactability. Not only which patients are likely to use have such heavy utilization, but which ones can we affect? Which ones can we change the outcome? Monitoring a patient whose outcome you can't change challenges the economic value of your program and its sustainability. Impactability is a relatively new idea. If you read the literature, world's literature on impactability, most of it says we need to do a better job of impactability, but it's a critical part of the process. And then create a set of devices and measures appropriate for the patient's array of diagnoses and avoid the one-size-fits-all approach. Only then, if you have a realistic model that allows you to picture and understand the nature of the patient's existence at home and what things trigger their problems and what things make them better, can you then move on to the next step, which is machine learning. Because we're trying to do something that's relatively new. We're pretty good at identifying when a patient is sick, not quite so good at knowing when a patient 4 or 5 days from now will be sick. So that's going to require machine learning if we have a good model. So what we do is we identify the patient, we predict which patient's going to be sick. Okay. We track the intervention that the care team provides, we look at the outcome, and we feed that back into the system. If we were correct in predicting this patient was going to be sick, that's a true positive that gets fed in. If we were incorrect, that's a true negative. Or a false positive that gets fed in, and it improves over time. And so we're simultaneously looking at the accuracy of the prediction method, improving it, and also tracking the intervention and outcome. So we will be able to learn over time what works best in the patient who has CHF and COPD and diabetes, because we're not going to learn about that complex management any other way other than working in the real world. And I thank you for your attention.
So just a few high-level comments to start off with, and then I'll talk about what we're doing at Memorial University. So just a reminder that the focus of all this work is on health. We expect that we'll have some issues with our health during our lifetime, but by and large, if we can have people live healthy lives, they have the benefit of that health, and healthy people cost less money to care for. So that's sort of the business value that we're going after. And in terms of using big data and analytics for it, like some of the speakers before me have said, we're using this to gain more knowledge about healthcare. We're using this information to apply that knowledge to specific individual cases, and we're also using it in terms of organizing and operating and allocating the resources for the healthcare system. So why are we doing it now? Some of the technology that is being used in other industries is quite amazing in terms of its capability to deal with big data. And for example, even healthcare is using it to deal with the large amount of data that's being used for genomic analysis. And it's hard to overemphasize these changes. I mean, literally it's costing 1/1,000,000th of the cost to store data that it did just a little while ago. So new technologies to gather data and connect them to computer systems, new technologies to store them, and also new capabilities in terms of analyzing that data and being able to deal with these large data volumes and do computations in parallel and gain insights from it. We've also learned in other industries about methods of doing process management and lean processes and being safe and being effective, and there's opportunities to apply this in healthcare. And finally, there's a recognition that these health inefficiencies that Marty showed in his first slide, they are not going to be solved by a new pill or a new procedure or a new specialty in medicine. They require a coordinated effort with patients themselves, because patient behavior has a significant impact on health outcomes. And that is something that hopefully this technology can help with. Adult behavior change is very difficult. It's among the most difficult things, but it is possible to transition from behaviors that are leading to illness to behaviors that produce healthy outcomes. And there are ways to facilitate that transition. Just saying you should do it or just giving some advice in the doctor's office has been shown time and time again to not be sufficient, right? But if there's kind of a health GPS that knows where you're at, knows about the experience of a million other patients, and knows where you need to get to, it can perhaps help guide individual patients to a healthy outcome. And, you know, if you mess up along the way, it's not judgmental. It just says recalculating, gives you some more advice. So those potential changes and use for this technology. So this is just a high-level overview of such a big data analytics system. I won't go into too much detail on this. I'll just say that the majority of the work is often on the left, where you're getting connectivity and getting the data into a system and getting it in a state where it can be analyzed. On the right-hand side is where the analytics happen. Most of you are probably familiar with the kind of reports that, for example, come out of Chi-Hi, where you can look at specific measures and counts and drill in different dimensions. You can also have analytics that use models to do predictions, like Marty was talking about, and make recommendations based on those predictions. And then also there's this area of cognitive and machine learning, and I'll just say a few comments about that. So yesterday in the Journal of the American Medical Association, there was an article talking about machine learning and its likely potential significant impact on clinical care. So most of the computer interactions that we experience day to day, somebody has given specific instructions to the computer about what to do. Okay, it's been programmed to behave the way it does. What's different with machine learning is that you have these algorithms, and as Marty mentioned, you often need to spend some time building an algorithm that's relevant for your specific use case. But having done that, then you just feed it data. And you feed it data about factors that determine a specific outcome, and that model gets trained. And one of the use cases they mentioned in this article yesterday was pathology images, and then the prognosis for the patient. And the computer was able to discover a new feature about these pathology images, which nobody had recognized before, which had a significant impact on prognosis. And going forward in healthcare, there's going to be all kinds of those come along, because as anyone who's practiced healthcare knows, it's just pattern recognition. And that's one reason why you don't get to be a great doctor until you've done it for at least 10 years. So just a couple comments then about the projects that we're doing in Newfoundland using this high-performance cluster. It's also being used for some genomic analysis as well. So I'll just maybe highlight a few of these on the list, and if you have any questions about some of the others, you can talk to me later. So lab utilization, we're looking at some specific categories around kidney function, iron testing, and cardiac enzymes, and not surprisingly, we did find some inefficiencies there. The approach that they've taken so far is just to contact the doctors who are the outliers in terms of use and sort of an education session. But going forward, I know the dean there, Jim Rourke, has a real interest in trying perhaps to produce some ongoing reporting to physicians to help educate them in terms of appropriate utilization. And it's not just overutilization. Some tests are being underutilized as well that could have a better impact on better health. Long-term care, of course, one of the big things there is trying to predict the need for resources in the future. In addition, we're trying to look at the transitions. Under what circumstances does a patient transition from home or just assisted living into a nursing home? And are there interventions we could take in that circumstance to perhaps delay that transition for several months or even a year? And finally, remote patient monitoring. It's very much a use case like Marty just talked about. It's actually a project that Eastern Health was undertaking before I became involved funded by Canada Health Infoway to look at patients who are being discharged with congestive heart failure and chronic obstructive lung disease. And they're monitoring them at home with weight, blood pressure, pulse oximetry. And there are 4 clinical nurses who are following these patients and looking for opportunities to proactively, increase their dose of Lasix or put them on antibiotics in order to keep them from coming into hospital. It's very early on. We only have about 2 months worth of data so far, so we haven't been able to build up any predictive models, but that's one of the goals of that project. So then, in summary, it's really about transitioning the focus for the healthcare system from reacting to keeping people healthy. I saw some statistics a few months ago from, it was showing loss due to structural fires in Canada. And the losses over the last years have really decreased. And that's not just because we have really fancy firefighting equipment. It's not just because we have firefighters on every corner. The reality is that our buildings are really healthy. And we work hard to keep them healthy. And we have detectors that when they become unhealthy, we react really quickly. And it's a similar concept. And I think I realize there's lots of real challenges in healthcare. But at the same time, that potential to go from the state we're in to the state where people live healthy lives and don't have a lot of healthcare costs, to me, is you don't have that big gap in a lot of other industries. So at the same time as it's a big challenge, there's also that big opportunity. Thank you.
Mohamed, tell us about what's happening in Wellington, Waterloo, my old stomping ground.
Guelph is still doing great stuff. So you talked about the patients that go into the ER and then come back to the ER, and there's a challenge with identifying those patients. In primary care, when you're seeing, and we'll talk about it in a second, 25 patients a day, you're just slogging through trying to get through those patients, and there's no mechanism to identify those patients and actually do something about them. So I'll talk today about some of the work that we've done in primary care, the great, mostly uncharted waters of primary care, and how we're starting to do stuff on the front end that's supporting that back end. And hopefully it's not a horse, maybe it's a fighter plane or something like that. But we'll talk a little bit about what we're doing there. So if you go to the next slide. We talked about opportunity. So there is a tremendous opportunity in primary care. The majority of care, by some accounts, 80% of visits occur in primary care. In Ontario alone, we have 8,000 family doctors who have an EMR, about 85%. And I think I can see Sarah here, Ontario MD, has done a wonderful job with that in terms of getting EMRs in the hands of clinicians. Clinicians, family doctors see about 25 patients per day, and that's about 200,000 patient visits for EMR-enabled clinicians, where they document mostly unstructured data in their EMR, mostly in the form of encounter notes where you're talking about marital issues, and you're talking about their toe, and you're talking about heart failure, all in the same visit. And so the challenge is, how do you extract that and do something with that? The other challenge is, how do you support the clinician when they have a patient who went to ER with congestive heart failure, actually implement best practice guidelines in the EMR? And so we'll talk a little bit about what we've done in that regard. The data, mostly unstructured data. There are defined fields in the EMR, the patient summary or the patient profile, where things like medications probably done a little bit better. But we've even had challenges with that, taking the medications from the EMR and exporting them to the HealthLinks tool, for example, has been quite challenging. So there's lots of work. There's also different types of data. There's scanned images, there's consult notes, different format for forms, as well as lab data in the EMR. So a lot of data, and we're not getting very much value from that data. So if you go to the next slide, the other problem is clinicians themselves, and so I can say this as a physician. We like to express ourselves, so I'll only take an hour today to talk to you about this. No, not quite. I've been given 10 minutes, and there's a timer in the front here who's going to keep me to that. But clinicians like to express themselves. We know from the literature they use the EMR as a sounding board, right? Question do they have COPD? I haven't done the confirmatory testing, and in many cases, it actually never gets done. 25% of patients with COPD don't have the confirmatory testing done. So there's a problem there, and there's an area of action, somewhere where we can provide value to the system of getting those patients their appropriate testing. But 701 ways to represent diabetes. Kai did a great analysis of this through the Primary Healthcare Volunteer Reporting System, looking at data and EMRs and the challenge of extracting that data and actually getting value from it. I'm not sure what the 701 ways are, and people ask me, like I think they came up with diabetes when ants were crawling towards urine because there was sugar in the urine. I'm not sure if that's what people still write in the EMR, but it's quite interesting how many ways you can capture something in when you think it'd be pretty simple, but it's not. The other challenge is keeping charts up to date. We've been doing some analysis with getting them out, and we're looking to share primary care data as well. But if you have 5 antibiotics listed on the patient chart, I doubt, unless they have TB, they're not taking 5 antibiotics. And so there's a big problem there for clinicians to keep those charts up to date. The average family doctor is about 1,600 patients, or 1,300 to 1,600 patients. It's a huge challenge. So how do we support clinicians to do this? And the last thing is, and we've heard from clinicians, that they want to support better data. They recognize the value of this data for the health system, for their own practice, but they care way more about patient care, about that patient in front of them. And so if there's extra clicks on their computer screen, if they've got to go through all these ICD-9 or SNOMED codes, they're not going to do it. So how do we support clinicians in standardizing this data? And so in the next slide, I'll talk to you about how we did that. So we worked with 2 family health teams. So these are interprofessional health teams. In one of them, we standardized 18 conditions in the EMR. So we coded them using both ICD-9 and SNOMED. This team had about 24,000 patients. And then what we did is we had a team go in, they coded the data. We then went back, and the team left, went back 6 months later, 85% of the diagnoses were still being coded by clinicians, which is amazing, right? Clinicians don't code, right? One of my colleagues says, if you care, you'll code. And I think physicians are getting it. So 85, and in fact, when they put an admin person to help out, physicians, it was over 90%, about 95%. So clinicians will code if you give them the right tools to do so. What we were able to find from this analysis, about 7,000 patients had multiple chronic conditions, and so we were able to break them down by the number of conditions that patients had, and we're able to then build different tools in the EMR to support these patients. So, for example, and what we'll see on one of my last slides, is for patients with congestive heart failure, you can actually put a reminder in the EMR to give them a pneumovax, a pneumonia shot, and we had great success. We actually built a medical directive from that, where clinicians and doctors are lazy, right? So they look at the EMR, they're not going to do all the alerts that pop up, alert fatigue. We actually got the nurse to put a reminder on the keyboard. You need to get this patient to get their shot, and the nurses were then able to give the shots. And we did the same thing for diabetics and renal function tests. The nurse was able to print out the lab rec, put it on the computer keyboard, so the physician could not ignore it, and then they would just sign off and give it to the patient, and we'll see what the results of that were coming up next. We were able then to take this data, and if you flip to the next slide, able to put into some models, to some predictive models that are out there. I'm sure you're very familiar with these, and look at how these lead to patient complexity scores, and how can we identify these high-risk patients. So in Ontario, where you look at, we're talking about health links, we're talking about sub-LHIN geographies. How do you identify these complex 1% and 5% of users that use all these system resources? The definitions changed over time, but the definition that we're sort of at right now is looking at multiple chronic conditions, mostly from acute care, so we can do a great job with that. We've started to do that in primary care. And we've started to take that data, and now we're looking at linking it up to the acute care data. So if you miss that patient has COPD and they came to the ER for whatever reason, that's an important piece of information that should be communicated. So we're trying to find those gaps and then trying to have this system view of that patient. How do we get that so that everyone knows this patient has COPD and that you need to give them the antibiotics and the steroids if they have an exacerbation. If you go to the next slide, we've also added other things into this as well. So smoking status, alcohol use, sex, and age. And so are using this in predictive models to identify these complex patients. And then we're able then to refer these patients into these interdisciplinary teams which are looking after them. So this health links model that I talked about, that I know a lot of other provinces are looking at as well. So we're using this to provide value to clinicians, to patients, and then to act on it. This is the action. We're getting these patients into these teams which can help them stay out of the ER, for example. In the next slide, I'll show a model that we've developed. We've looked at disease burden and how that links into things like high costs in the system, and start to map these conditions and the significance of these conditions from primary care data to disease burden. And so we can look at what type of programs now do we need to establish for these patients from a primary care perspective. Not billing data, this is actual clinical diagnosis of patients. So then the teams and these health links can start to then organize programs around these patients. We need more CHF clinics, and so actually this is what we're doing. We're looking at CHF clinics, community-based CHF clinics run by family doctors, supported by cardiologists to support these patients, because that's a significant problem. I think we all knew that. Heart failure is a big problem, but we're able to look at things like osteoporosis and other things and identify what are the top 5 that we should focus on and build programs around. If you go to the next slide, so this is the action. So that simple coding of patients with diabetes, printing out that lab rec, the nurse putting it on the keyboard, increased the number of creatinine tests done by 109%. So there were, hundreds of extra tests appropriately done for these patients with that potentially could have chronic kidney disease and could lead to dialysis. And so now we're catching them early. Patients with the CHF, we decreased the number that were unvaccinated for pneumonia by 82%. And so those patients who end up with pneumonia go into hospital, they're frailer, they have poor outcomes. I don't have an exact stat for CHF, but for COPD, immunizing them with influenza and pneumonia vaccines decreases the morbidity and mortality by 50%. So significant things that we can achieve by doing things in the EMR. And so the important thing is we're doing these in the point of care systems, where then physicians can act on them right there. Secondarily, you can take that data and you can pump it wherever you want and look at analytics and look at different things to support the system use. So there's both benefits, but we're getting clinicians to actually make changes on the front end. We've also been able to link this to templates. So there's guidelines for everything. And so what we've done is once you identify those patients, we facilitated the integration of templates in the EMR. So we've, for example, got our Chronic Disease Council or Cardiac Care, the National Cardiac Care Network to endorse a CHF template that now you've identified these patients, you should use this template that incorporates best practice guidelines. And so they click on this patient has heart failure with reduced ejection fraction. It pops up triple therapy. This is what the patient should be on. These are the target doses. Where are you at? If you're not at target, what are the reasons for it? And then we can actually share that with cardiologists. So once you refer that patient, the cardiologist said, I want that template. In fact, some of them wanted it in their own EMRs, but now we could actually send it with that patient to the cardiologist. And then finally, we've, people talk about resources. You need a lot of resources to do the standardization, and so it's not feasible. I've got 3 docs in an office and 1 admin assistant. Well, we've developed a model for that. So we understand the resources required to standardize data, to continue that standardization, and the support that the clinicians need. So we've developed a model for many different types of practices, but also many different intensities of standardization. You may not standardize all 100 conditions, although we're actually working with CIHI to do that in some EMRs now. You might want to standardize 5. We have a model to support clinicians in doing that. So a lot of work ahead. This is just the beginning of the journey. But I think it's quite exciting, and we've learned from a lot of you. We did an environmental scan across the country before we started this work. So we hope to continue to work with all of you to move this forward. Thank you.
Heather, tell us about Game Changers.
Well, thanks very much. I'm Heather Bryant. I'm with the Canadian Partnership Against Cancer, and if I were to describe what our role is in the simplest possible terms, it's to implement a pan-Canadian cancer control strategy. So there's key words in that: implement, and pan-Canadian. So the kinds of things that we're talking about are not things that can only be done within a clinic, but what's really going to make it a game changer across Canada. So I'm going to take us through a fairly concrete example. As many of our colleagues have said, if you're going to do anything that's going to improve healthcare in Canada at any pan-Canadian level, information is core to all of it. And so what are some of the things that we've done with our partners across the country to try to move the yardstick forward? And the example I'm going to use is synoptic pathology reporting. Now, pathology is really important in cancer control because pathology is where the diagnosis starts. If you don't get the diagnosis right, you actually aren't going to get the treatment right. It's very core to everything that we do. And so making sure that you have the exact information that you need in a credible, quantifiable way is core to anything you're going to do in cancer control. And I actually think we've done it sort of in 3 stages. First is translation, the actual understanding what it is we're trying to do with these forms. The second is the transaction, how to make the actual transaction with the patient better. And then the final is the transformation. How do you transform the system? So this is kind of like Mike Green and David O'Toole were saying. One's about the patient care and the transaction, one's about the transformation. So just a little more. The translation. This is about developing clinical consensus on the key indicators to be collected. So this isn't information consensus. This is by the clinicians who say, these are the things that we would really need to predict the prognosis for the patient, to look at the quality of our work, to look at the quality of the work of others, which they actually usually like much better, is looking at the quality of work of others. But these are the things that are core, and then translating them to uniform reporting standards. The second is transaction, so developing the systems and formats that actually maximize the impact on each episode by improving the quality and or the timeliness. So a lot of these things, as I'll show you, the timeliness is another important thing, and that has been an issue in pathology in Canada. And finally, to transform. So while you do all of this, we all want better patient care, but if you don't think going in, what's the data that we need out of this to actually be able to analyze it to make the system better, you're not going to get it by accident. There's no point in having a number of continuous variables like blood pressure if average blood pressure isn't going to tell you anything. You actually have to kind of figure out how you link that back to treatment and what is the indicator you want to have. So that's the transformation. So I'm just going to walk us through a little bit more about this. This is a standard on the left, a standard narrative report. Now, if it was a narrative report in surgery or in primary care, it would always start with, this pleasant 43-year-old woman, because we always say our patients are pleasant. This is a pathologist, so they don't have to be bothered with that minutia. They just talk with, how big is this thing I've got in front of me? But even with that, with a narrative report, the parts that are in yellow are the parts that are important. The rest of it is just verbiage around it. When you get to the synoptic report, each one is listed on a separate line. You don't have to dig through a paragraph to find it, and you know exactly what the values are, and then this is the whole idea behind it. So the translation part of this was to say, so what are those things that we need in the synoptic report? What are the things we need to drive it forward? And this was done through work of a number of colleges of American pathologists, as well as the Canadian Association of Pathologists, who together worked to devise the content standard. And I think this was key. We actually haven't moved forward as quickly, for example, in synoptic surgery. And part of the reason for that was we didn't go through this process with a group that's saying, what are the core variables we need to move forward? People developed some long, long lists of variables that would be wonderful to have for whatever research paper you might imagine in the future, but then the surgeons wouldn't fill it out because it became too long. And so how do you get down to the core things that you need to move clinical practice forward? And you can see they developed many clinical standards around those using very well-known informatics tools. So how did this get to the improvement of the transaction? Well, a number of things. First of all, although the narrative reports were quite long and verbose, there was actually missing data in very many narrative reports. And if you look at this, and you look on the blue is the narrative, and this shows the percentage of missing data or complete data rather. So the missing data in colon rectum, for example, they only got 30% of the data they actually needed for the key variables in all of this verbiage. And we're missing 70% of what were agreed to be the core things. By having a form in front of you, it kind of reminds you, gee, I should say something about that. Or even worse, maybe I should have looked at that. And so it actually helps you improve the quality of care as you go forward. In terms of the transaction, the acceptability, this was something that was thought to be a bit of a problem going in. Maybe the physicians wouldn't like to have this, maybe the pathologists wouldn't like doing it. The clinicians actually much preferred this, and it's for a couple of reasons, and so did cancer registries. Cancer registries get data directly from pathologists. They exist primarily from the reports the pathologists put in, and that's how we have all the data that we do have on cancer in Canada. And in all of that verbiage, pathologists would say things like, this has a number of the characteristics of a probable carcinoma. And the clinician would say, so what is it, cancer or not? What do you think it is? Well, the pathologists were feeling a little bit pressured at first about the pressure of actually making a decision, but who better to make the decision than the person who has the training and the access to the specimen? So they got onto that, and you can actually say on a scale of 1 to 5, the clinicians gave this 4.85 satisfaction record, and the pathologists were also over 4 out of 5 in terms of their preference for this synoptic reporting style over the narrative style. And in addition, it was also a lot more timely because you didn't have to send it in, you didn't tape it, you put it in, you wait for a week for the transcription to be done, and then it has to go in the chart and everything. It just can go directly to the people that need to receive the information. And transformation. Well, the key issue is to decide on those questions that would actually drive patient care and the system forward. Not every indicator is valuable in and of itself. Some of them might be valuable for patient prognosis, but not for the system. What kinds of conversations can you have around that? Well, this shows you some things that have been measured before, and it does show you some evidence of improvement as you go on. This one looks at prostate margin rates, and the dark green is the bad. And as you see, the percentage that had prostate cancer still in the margins of the sample, so it means you didn't get it out completely, went down over time. We have great data from across Canada now on requiring 12 lymph nodes to be taken out in colorectal cancer. The reason for that is if you only take out a couple, how do you know that they were node negative? How do you know that there wasn't any cancer in a node? You only looked at 2. You have to look at a minimum of 12 before we'll say, yeah, if you don't find any in 12, we'll say they probably don't have any. And we know that that is up above 90% in most provinces now. So that has moved up over time. You can do report by hospital, and of course you can do reports by practitioners as well. And these have been shown to move things forward. The development cycle for the indicators goes on. So the identified relevant indicators, a literature review to look at it, you get clinical input, you refine the content, you map it back to the things you have in the Canadian Association of Pathologists regime, you do the alignment, and then we do a clinical validation and we do a consensus on what actually we want to move forward. So we're with that stage with our experts right now saying, so what are the 5 or 6 things that we're going to report on in the next year from these data we've collected? And we've done it in 6 tumor sites. This shows you information from 3 of those, just because the font got too small with 6. So these are 3 of the tumor sites, and this is what they've agreed on, as these are the key variables they're going to report on next year on a pan-Canadian basis for those that are participating. The orange ones, and there should be 1 more orange ones, are the ones that really talk about quality. Margins, margin status, number of lymph nodes, and so on. The other ones are fine points about prognosis and indicators that we need to not only care for the patient, but also look at things like if the survival isn't as good in one province as another, is it because the treatment isn't as good, or is it because they actually come in at a later stage? And we can look at this and have a better indication of which parts of the continuum are affecting that outcome. Now, this shows you sort of the trajectory we've gone on. This is a smart art. I'm sure you will all recognize diagram, and smart art is much more optimistic than real life. And it shows, we started with Ontario, New Brunswick, then we went on. We've had a few glitches along the road because there's very real implementation issues. One of the provinces here, Alberta, was very much in and was participating in this, had to back away because they couldn't get priorized by their IT team. And so they wouldn't be able to be finished by the time we need to be finished because of our funding formula by March 2017, but they're still very much engaged at an expert level, and they're still going forward, so when they do get to the top of the list, they'll be able to go ahead. Another thing that happened was a vendor that was chosen by 3 of the provinces to be the vendor of choice to actually implement this, orphaned it. Moved it on to another, and so we had to look at other ways of moving on with synoptic pathology with that vendor and others. So just some other related CPAC initiatives. We are working on synoptic surgery, and we're back at the developing standards and further implementation. One area I think that is quite interesting is the patient-reported outcomes, and this is not patient satisfaction. This is patient-reported outcomes that are important to cancer patients, and so it's captured now in 8 provinces across the country as a result of what we've done with our pan-Canadian work. And what it looks at is things like fatigue, pain control, shortness of breath, anxiety, depression, common things that affect cancer patients, and looking at what we can do to also ameliorate those. So I think there's quite a bit more to go on with those. I will say, having said this, we've got quite a bit of data getting forward. What's going to happen with the analytics? What's going to happen with the data storage and linkage? How can we use this to enrich the data sets overall? And how do we get those results out? Those are things I think that we'll discuss over the next day and a half. Thanks.
Thank you very much, Heather. I'm impressed that you got so many pathologists to agree on anything. It certainly wasn't about remuneration for services, that's for sure. So now it's your time to ask some questions. I'm going to use my prerogative moderator to put the first question in there. And I guess from where I sit, I've got a sort of a split brain. Part of me has focused on in my life in terms of how do we improve access for patients, for consumers, and I think the technology is increasingly allowing consumers and patients to have a more direct involvement in their care, and that's going to increase with technology, and I think that's a good thing. And on my other part of my brain, it's all about money and about cost. And so my colleagues and I recently met in Vancouver and talked about a new shared health agenda, which some people like to call an accord. And as we talk about that, one of the items on the agenda around innovation. So we're very excited about that, and analytics is a part of that conversation. So I guess part of my question, and I'm going to pose the question, and you can all sort of give me your answer to the question. As we move towards developing a pan-Canadian health ecosystem, which is a recognition that we have a very evolving landscape of technology, and the ability to use that information in an open architecture, interoperable way is what is before us. One of the challenges that we face is to convince my finance colleagues across the country around the benefit and investment in health information technology. There are many horror stories across the country. I don't have to tell you specifics around promises made that weren't delivered. And I think that's one of the significant barriers that we have to talk about. So my question is really, how do we convince rational business types that the investment in healthcare this time will really pay off, and what should we avoid going forward? So who wants to take that question first? You can sit down because you've got microphones on.
Okay, thank you. Yeah, I think that's a real issue, as I alluded to. In the past, just developing the technology was enough. Now we have to prove real value, because we've been, our industry has been damaged by overpromising and under-delivering. So, for example, with Sentrian, our primary target group for partners and clients are organizations that are both payer and provider, in the accountable care-like model, or the NHS in England, where for them every avoidable admission is a win-win. It means improved outcomes and controlled costs. And we actually develop academic publications to demonstrate that impact. But we've also had some learning along the way in terms of producing the value. As I mentioned also earlier, we're very good clinicians are very good, experienced clinicians are very good at, intuition as to when somebody is really starting to get sick or is sick. One of the things we have found, since we're starting to predict which patients will be sick actually days before they become symptomatic, is the care managers and nurses still revert to their normal intuition, and they'll call the patient and say, "How are you feeling?" And the patient says, "Fine," and miss the opportunity to intervene in the pre-symptomatic stage. So there's a lot of learning that goes into this, but ultimately you are correct. We need to show both improved clinical outcomes and economic value if people are going to actually, if we're going to both transform healthcare and have anybody interested in what we're doing.
Thank you, Marty. Any other thoughts?
No, I mean, I would agree with that. The value of using the same scientific rigor that we've used to prove the value of drugs and procedures and applying this to these analytics systems. And also, I think, I don't have the exact answer to this, but I think there's an opportunity for collaboration between different disciplines. I mean, a lot of the projects that I've been involved in IBM with have been essentially open source projects, right? I mean, the company carved out its niche and part of the overall scheme, but the code we gave away, right? Just to broaden the use of the technology in the domain. So I think there's some innovations that can happen there.
I think it's a difficult question because I think we have a long history of not really using the data that we do collect. I actually think we may need to say, what are the 5 big questions that we have, and can we actually show, if we concentrated on those, that we could come up with things that would move the system? We might be able to whet the appetite for more. But I think the tendency is to let little pockets of genius spring up, and we end up with a number of pilot projects that don't ever deliver the big benefits, don't ever make it possible to persuade others. So the key to the pathology one was getting the key pathologists involved. Now 67% of the pathologists in the country will be reporting this way by 2017. That's the kind of influence you have to have. But if you start with an IT idea, you aren't going to get there. It has to start with the content and what you're trying to do for the patients.
So I agree
Thank
with
you.
that. And just building on that, so we've been able to in the EMR identify patients with certain chronic diseases and have recognized that patients aren't identified in the EMR. So we looked at 2 patient groups, those with COPD and mild cognitive impairment, so pre-dementia. And if we were able to accurately identify these patients who weren't previously identified and then implement programs around them focused on decreasing hospitalizations and ER visits, we were able to, and then we extrapolated it to the province of Ontario, which you shouldn't do actually, but it was about $13 million per year for these patients. And for our LHIN alone, it's about $1 million per year, just from those 2 patient cohorts. So it's really the ability to identify these patients who are at high risk, complex, from the data, and then implementing the action part, implementing programs around that. So again, preliminary results, but I think that there's great potential here with using the data to help drive programs around patients and then decrease costs.
Thank you. Well, I could ask all the questions, but I'm not. I'm going to turn it over to you, and you have some microphones across the room. We have a few minutes now to open up your questions, so please, if you have any questions, come to the microphone. If you could identify yourself and where you're from, that would be fantastic. So please ask our panels any questions you may have around game changers and predictive analytics, and I think I see Janet Davidson coming up there.
Thanks, Peter. Janet Davidson, I'm Vice Chair of CHI, former deputy in Alberta. I wanted to ask the question, and you talk about the fact that you need to focus on the individual patient. How are you involving individual patients in this? So, I remember talking to somebody from the UK who said the individual patient lives with whatever they've got 24/7, 365 days of the year. So you come up with clinical protocols and you come up with decision support tools that have an impact on how the clinician, and I use clinicians broadly, are trying to provide and support the care to that individual. But how do you actually work with the individual for the other, how many thousands of hours that they have a year in managing their disease? It seems to me we're still in this position where we seem to be coming up with something that we will apply to the patient, as opposed to having the patient or the individual actively involved in designing and delivering that care themselves?
That's a great question. That's a real game changer. How do patients actually be involved in their own care?
Actually, it's an excellent question and at the core of the issue. The approach we have taken is actually extending it to not only the patient, but what we call the LOCG, the loved ones and other caregivers in the patient's surround, and we engage all of them. One of our executives has as his total responsibility engaging with the patients. And part of the machine learning process, if you will, is what interests the patient, what motivates them to participate, what things don't they like, and we change as we go along. So we have, I mentioned some of we can measure typical physiologic measures, pulse oximetry, heart rate, and so on, but we also have a tool that allows the patient to report his or her own observations. I feel more short of breath than yesterday or less anxious than yesterday, and engage them. And we learn over time. In fact, we're submitting a publication this week on the patient response to the system and what they look for and what they want. Because without that, if we engage the patients in a way that doesn't interest them, then they drop out after a couple of months and nobody has gained. So it is a large focus of patient-centered care, in fact, to engage each of the patients in a way that they think is going to be beneficial to them.
Heather?
So thanks, Janet. I think there's a few ways. In terms of the pathology example, anybody who's watched CSI or Quincy doesn't really want a pathologist as part of their day-to-day life generally. And it's really more about getting the result quickly and the result definitively. But there are several examples here in the patient symptom scales where the patients have actually driven the development of those. They've driven the development of what are the important constellation of symptoms. So fatigue, shortness of breath, those are things that often will just get recorded as a line if they get asked at all, but they've been found to be the things that really do affect mostly their quality of life as a patient. It's only by collecting that data and then seeing whether you can change it, and that's sort of where we are right now. All sorts of groups are saying there are things we should do about their psychosocial needs. Nobody's really in a position to say, are we making them any better? And so that's another way of dealing with that. The third thing I'll say is we are engaging patients more and more in looking at the results, in having a voice, just sitting at the advisory committees around these and helping to translate as well what they think the impact should be and which of these things should be made public as we go forward. And I think that's making it a healthier system.
Mohamed?
Add to that. So we endeavor to have patients on every steering committee that we have to get that feedback. And for some of our chronic diseases, what we've done is we've sent out surveys before the visit to patients, so secure to their email. Yes, it's to Gmail, but it's within a secure wrapper, to identify what's important to them. And once they identify that, when they have this visit with their clinician, the clinician knows up front, yes, I've got this checklist and I've got this best practice protocol to go through, but they want to talk about their mom who's unwell and they're caring for their mom, and so they're not able to sort of maintain this rigid diet with a decreased salt intake because they're traveling a lot. So we endeavor to do that, and the other thing we've done is deploy tablets in the waiting rooms where patients can enter data while they're waiting, and this will feed into the chronic disease template so that we have that information up front. But I agree, we need to do a lot more engaging patients and getting their feedback. Without patients, we're not gonna, without their feedback, we're not gonna get very far.
And we've had a similar experience, Peter, with our home patient monitoring. They have an iPad in which the patients can provide clinical symptoms. And I think, going forward with machine learning, there's all kinds of opportunities. I was talking with one of the rheumatologists a couple weeks ago, and one of the challenges is just, first of all, triaging patients who have arthritic pain. We were talking about pain in the hands, and just talking about getting them to take a picture of their hands and send it in on a regular basis. And there are definitely specific changes that help differentiate between inflammatory and non-inflammatory arthritis. And it's possible that the machine could just, look at these, learn over time, and flag thing. So I think there's a great participation, and even just giving feedback on how treatment outcomes occur. You know, we get data from the electronic health record, but actually a lot of that doesn't contain what actually happened after the patient received a treatment.
Thank you for the question. I think we're just about up with our time. So I just wanted to thank our panelists for some great examples of work that's going on. I think we have some challenges across this country to try and take the work of so many excellent pilot projects and sort of try and weave something together that actually scales that across systems. And that's been our challenge in Canada. We've been called the land of pilot projects, and there's a great deal of truth to that. The opportunity is to try and scale up some of these great initiatives going forward. So I want to thank our panelists for their comments, and I want to thank you for your time today, and we look forward to greater conversation as the day moves on. Thank you.